Hey everyone, and welcome to today's Explainer. We are going to be unpacking the basic principles of high-flow oxygen therapy. We're going to break down the core physiological mechanisms that make this technology absolutely crucial for modern airway management. Look, whether you're dealing with complex airways every single day, or you just really want to understand the hard science behind modern oxygenation, you are definitely in the right place. Let's dive in. To set the stage, our framework today is heavily guided by the incredible work of Professor Rakesh Garg from AIIMS, New Delhi. His extensive clinical research in this field brings a ton of unparalleled authority to what we're going to talk about.
So, here is our roadmap for today. Number 1. Introducing high-flow oxygen therapy. 2. Core mechanism, apnoic oxygenation. 3. Core mechanism, dead space washout. 4. Oxygenation versus ventilation. And finally, number 5, physiological limits and takeaways.
All right, kicking things off with Section 1, Introducing High-Flow Oxygen Therapy. Think of your conventional low-flow oxygen setup kind of like a garden hose. It completely caps out at around 15 liters per minute, it delivers a totally variable amount of oxygen, and honestly, it completely fails to match the patient's actual inspiratory demand. Plus, it lets room air just mix right in. HFNO, on the other hand, it's basically a fire hose. We're talking heated, humidified oxygen delivered at massive flows, like 30 to 70 liters per minute for adults. It gives you a super predictable inspired oxygen fraction, or FiO2, all the way up to 1.0. And this isn't just about patient comfort, right? It literally doubles your safe apnea time compared to a standard conventional face mask. That's a huge deal.
Moving right along to Section 2, Core Mechanism, Apneic Oxygenation.
The sheer magic of apnoic oxygenation really boils down to one massive physiological mismatch. Picture this. During apnoea, so when a patient has completely stopped breathing, the body is still aggressively consuming roughly 250 milliliters of oxygen per minute straight out of the alveoli. But at the exact same time, only a tiny fraction of carbon dioxide, like 10 to 20 milliliters, is actually returning from the bloodstream back into those alveoli. This huge discrepancy creates a subatmospheric vacuum. It's literally a negative pressure inside the lungs that continuously sucks fresh oxygen inward.
So this all unfolds in a really distinct cascade. First, as oxygen diffuses from the alveoli into the blood, that little drop in pressure physically pulls more oxygen down from the pharynx. And here's where HFNO steps up to the plate. It acts as this massive, constantly renewable reservoir of oxygen right there in the upper airway. Toss in what we call cardiogenic mixing, which is literally the physical beating of the heart stirring up the gases, and this system guarantees a relentless, continuous bulk flow of oxygen all the way down to the alveoli. And the craziest part? It happens entirely independent of the diaphragm moving.
Now you might be thinking, okay, cool theory, but does it work? Absolutely. The clinical impact is staggering. Major meta-analyses, like the extensive reviews done by Silva in 2017 and Fuchs in 2024, show this mechanism directly translates to patient safety. We are seeing significantly improved first-pass intubation success, we're seeing way higher oxygen saturation levels during the intubation process, and a massively reduced risk of life-threatening hypoxemia during things like procedural sedation. It even safely maintains oxygen saturation in complex pediatric airways. It's a real game-changer.
All right, Section 3, Core Mechanism, Dead Space Washout.
Think about how normal breathing works. When you exhale, that air is rich in carbon dioxide, right? And a lot of it just lingers in your nasopharynx and oropharynx, what we call your anatomical dead space. Without high-flow oxygen, you inevitably rebreathe some of that stale CO2 on your very next breath. But by continuously blasting the upper airway with high flows of fresh, oxygen-rich gas, HFNO physically washes out that CO2-heavy air. This dead space clearance makes oxygen delivery so much more efficient and drastically drops the work of breathing for the patient.
Now, let's pause here because we need to clear up a common misconception. HFNO is a flow-based system. It is absolutely not a CPAP device. Yes, okay, it does generate a very mild positive end expiratory pressure, or PEEP, roughly 1 centimeter of water for every 10 liters of flow, which is highest when the patient keeps their mouth closed. But, and this is a big but, that pressure is entirely flow-dependent and incredibly inconsistent. You just can't treat HFNO like a mechanical ventilator giving rigid pressure support.
Okay, let's get into Section 4, Oxygenation versus Ventilation.
If you take only one thing away from this explainer, let it be this. Oxygenation and ventilation are not the same thing, at all. Oxygenation is simply getting oxygen into the blood, which we measure by SpO2. HFNO is phenomenal at this. Ventilation, on the other hand, is the elimination of carbon dioxide, measured by PaCO2. And during apnea, HFNO's ability to get rid of CO2 is downright poor. Because the patient isn't actively blowing off volumes of gas, that carbon dioxide is inevitably building up in their bloodstream at a rate of about 2 to 3 millimeters of mercury every single minute.
There is a quote that perfectly hits the nail on the head regarding this dynamic. It's basically the anesthesiologist's bottom line. HFNO buys time to intubate without desaturation. It does not buy safety from hypercarpenia or acidosis if apnea is prolonged. Stopping someone from turning blue does not mean you've stopped the silent, creeping threat of toxic carbon dioxide accumulating in their blood.
Which brings us to our final part, Section 5, Physiological Limits and Takeaways. As amazing as this tech is, HFNO is not magic. There are hard physiological walls it just can't break through. No matter how high you crank that flow rate, it's completely useless if there is a complete airway obstruction, like a bad laryngospasm, blocking the path to the lungs. It also can't fix severe intrapulmonary shunting, like you'd see in massive ARDS, where blood is just bypassing functional alveoli entirely. And as we just established, it absolutely cannot save a patient from severe ventilatory failure if apnea goes on for so long that they develop life-threatening acidosis.
So here is your final, massive, clinical red flag. You look at the monitor, and the SpO2 is sitting at a beautiful 95%. Looks great, right? Well, during tubeless airway surgery, deep sedation, or any really prolonged apneic event, that comforting oxygen saturation can give you a very dangerous false sense of security. Because while their oxygen looks totally fine, their CO2 could be skyrocketing, their pH could be plummeting, and they are silently becoming highly acidotic right in front of you.
So I'm going to leave you with this provocative thought to really challenge your day-to-day clinical practice. If a normal SpO2 during high-flow nasal oxygen feels safe to you, are you truly monitoring your patient's ventilation, or are you just masking the rising threat of hypercapnia? Remember, always treat the whole patient and their complete respiratory picture, not just the glowing number on your screen. Thanks so much for hanging out with us for this explainer. Keep learning, keep asking the hard questions, and we'll catch you next time.